Hi, and welcome to the Primary Care Collaborative's August webinar and the release of its report on better health and Medicaid through stronger primary care. My name is Sarah Agrino, and I've had the great pleasure of leading PCC's work on this topic over the last 6 months. Previously, I served as PCC's Director of Policy and worked at the National Association of Community Health Centers before that. First, a bit about the Primary Care Collaborative, known as PCC. PCC is a multi-stakeholder member organization that works to advance primary care as the foundation of a high-performing health system. So we do that through a few different ways. One is research and sharing best practices. We do it through advocacy around federal and state policies, and also by uniting stakeholders around shared priorities in primary care. So a quick plug, the organization will host its one-day annual summit on November 16th in Washington, D.C. with the theme Keeping People Primary, Building Trust and Better Health. So click the link in the chat. My colleague will place it in the chat now to learn more. So today's event, this work really started out of PCC's intent to advocate for stronger primary care in Medicaid through its Better Health Now campaign. And specifically as a key lever to close equity gaps. PCC's campaign brings together over 50 diverse organizations to push specifically for payment reforms in primary care. But before developing its Medicaid advocacy agenda, PCC, through funding from the California Healthcare Foundation, wanted to understand what are the most effective ways to strengthen primary care and Medicaid to improve access, improve outcomes, and improve equity. What does the evidence show? And so our report being released today attempts to answer that question, and our follow-on discussion will explore key themes around it. So here's our plan for the hour. Professor Leighton Koo will briefly overview PCC's report that identifies 8 payment and delivery reform specific strategies for strengthening primary care. That will be followed by a discussion with 3 panelists that come at this topic from a range of different perspectives, from state Medicaid agencies, consumers, and clinicians. And Rob Houston of the Center for Healthcare Strategies will moderate. And then we'll close by answering questions from all of you, our audience. So a quick housekeeping reminders before we dive in. All lines are automatically muted. We'll take questions from the audience in the last 10 minutes, but please feel free to share your questions throughout the hour. And the webinar is being recorded. We typically post them within 24 hours to PCC's website. We do host these webinars monthly, so I encourage you to take a look. There are a lot of great webinars spanning a range of topics within primary care. So now I'm happy to introduce my colleague on this project, Leighton Koo, to share our report with you and overview its key takeaways. Leighton is Professor of Health Policy and Director of the Center for Health Policy Research at George Washington University. He's a nationally known expert on Medicaid policy and access to care for vulnerable populations. Over to you, Leighton.
Thank you so very much, Sarah. So it's my pleasure to be introducing this report. I should begin by saying Sarah is being extremely humble. She is actually the main author of this report. Mostly my contribution was telling Sarah, yes, what you're saying sounds great. There were other contributors also, and we'll discuss the process that was involved in developing this report, which is a very thoughtful group process. Maybe first we can show the slide of the cover of the report. And so this is the report that is being released today. You can find it on the website. Some of you may have already found it. And so this is the report. Again, it begins with rooted in PCC's longstanding work in trying to improve primary care across the board. But here is a report in which they're particularly focusing on Medicaid, which is so important these days. Medicaid serves more than 80 million Americans. So it's really sort of is such a foundational program of providing health care for the country. And of course, it's for people who have low incomes who typically have the greatest difficulty in getting access to that. So we can advance, at this point, I guess I get to advance to the next slide. I'm having difficulty remembering the process here. So the process for the report was a very thoughtful process. We begin by sort of closely examining the literature. So if you find the report It helps examine a large number of reports. Many of the reports, in fact, were themselves literature reviews. So really, we're talking about research that spans hundreds of different studies. Next, we turn to a large number of subject matter experts in this area, people who have deep expertise in Medicaid primary care from a variety of perspectives. One of them, Matt Salo, is on the call today, but others who were involved, Ignatius Bow, Timothy Day, Hector Flores, Molly Gelberd, Tricia McGinnis, and Kelsey Berkman. So they were all helpful in providing their expert advice. Finally, we turned to an advising work group who were people who have been involved in practice related to Medicaid from a variety of perspectives, advocacy, working with health plans more actively. So we're familiar with Medicaid from the perspective of really being hands-on. And so that led to the development of this report, which we're, again, premiering today. And I'm going to try to give you a very quick summary of it. So there are basically 8 strategies. I've joked and called this the eightfold path of thinking about ways to improve Medicaid and primary care, and where possible, these are all evidence-based. So the first one is recognition that in general, there's a fair amount of evidence that primary care services in general, and in particular in Medicaid, are underfinanced, and that we need to be spending more. And some of this involves increasing reimbursement rates potentially for providers, but potentially doing other things to understand other efforts to expand primary care. So the first recommendation really is to try to bolster efforts to report the share of Medicaid spending that is going to primary care. There's been research that suggests that there's an inverse relationship between the expense to which services are being spent on primary care and the extent to which there's the need for things like emergency room and inpatient hospitalization. So again, if we can do things to examine that, and simply just a first step, an important step, is reporting and increasing this could occur at state levels or at managed care levels to understand that. The second is that closely relates to that is increasing payment levels. That is, in many cases, Medicaid reimbursement rates that are paid to primary clinicians. Medicaid, as you know, is a state-based program. So the rate that Medicaid pays to primary care physicians and other primary care providers, such as nurse practitioners or physician assistants, varies not only from state to state, but in many cases within managed care plans, there may be variations. So in general, the evidence indicates that Medicaid pays less than Medicare pays to primary care clinicians and less than is paid within commercial insurance. So one of the underlying concepts that comes through consistently is to increase the primary care payment rates to physicians. I will note there's a little uncertainty about how that would work. People may remember that in the Affordable Care Act, there was a brief 2-year period in which the primary care payments were elevated to Medicare payment rates. The research on that has been mixed. Some of the belief is that, however, that we didn't try that for long enough. A number of states have kept their primary care payment rates high in Medicaid. And in general, I think there's a broad recognition that across the board, we essentially speaking pay less to primary care physicians, and it's sort of the evaluation and management gets paid less than people who are involved in doing procedures. The third strategy is to support behavioral health and primary care integration. We are increasingly becoming aware that there is a mind-body connection and that we need to understand how to improve behavioral health. There are shortages in particular of behavioral health providers, but there's more that can be done to integrate behavioral health and primary care in a variety of ways. There are models such as the collaborative care model that have been used, that are well tested, that are widely used in a variety of settings, places like community health centers, successfully to do a better job of providing both behavioral health services and thereby improving people's health outcomes and vice versa. The fourth is to pursue population-based payment models. Sometimes these are also called as value-based models. These are models that have been discussed very broadly within the health policy sector over the past 2 years to try to figure out ways to provide incentives to have better outcomes and better use of better procedures. I will say there have been a variety of tests. The Centers for Medicare and Medicaid Services have been involved in a variety of demonstration projects over the past 2 years. A number of managed care programs and states across the country are trying to do these things. Nonetheless, I'll say there is still some of the evidence is still in development. Some of these things have not been in use very broadly. We've been learning a little better what works and what doesn't work. So there's strong belief that these models can be helpful. The demonstration data is not quite completely perfect. It's in development. The next is to stratify data and incorporate health equity quality incentives into payment models. Certainly, we are increasingly recognizing the importance of racial equity in terms of understanding health impacts that unfortunately disadvantaged Americans, and that includes disproportionately Black and Latinos, have more serious health problems, have greater needs. However, we don't always analyze the data that helps us understand where those differences might be, and then build in incentives to try to sort of make better health equity. Certainly, there are efforts that have gone into this in many years. CMS and HHS have really been trying hard to do this. We've seen certain changes like increases in postpartum care for Medicaid women that are intended to help support maternal mortality reductions among Black women. So there are more things like this that could be done. Sixth is one of my favorite topics, which is increase funding for community health centers and create new access points. We've realized that for many years, community health centers, which these days serve around 30 million Americans, about half of whom are on Medicaid, do an unusually effective job in combining primary care services along with other services together to really do a good job of improving care that helps reduce emergency room use, inpatient hospitalization, and frankly speaking, saves money. So increasing federal funding for community health centers could help. I will say this is an issue. Congress has yet to reauthorize funding for community health centers for the coming year. This will be something important to watch for. The seventh strategy is to pay for community health workers. Once again, in many cases, the emphasis that we've thought of has been in terms of primary care providers, and here we think of physicians, nurse practitioners, physician assistants. But there's a whole range of staff who can be doing things to help, and community health workers can be particularly important to the extent that they are able to better communicate and understand the needs of patients, in many cases do things like home visiting. And once again, there is data that shows that more support for community health workers really pays off in terms of improving health. And then the final strategy is one that's been going on for a while, which is to encourage patient-centered medical home attributes, including care coordination. There is a variety of data. This has certainly been going on for a number of years in Medicaid to try to improve that aspect of primary care. Strengthening, that's one of the distinctive elements that especially emphasizes improvements in primary care. So what we have as far as the sort of takeaway points is that we know that some strategies have strong evidence of success, others show promise, but they still need some time to demonstrate what they're doing. It's not as though we have a single silver bullet innovation that will solve all problems, but what is needed across a variety of communities and levels is a focused effort to try to do things that improve primary care and primary care policies, and to the extent that we can begin a conversation about what are those agreed upon sets of policies, that would be wonderful. In the end, what that will do is help create a sustained investment in primary care and have us develop methods to track the progress in this effort. What I'll say, one of the things that is creating a challenge here, we're talking about Medicaid, but we need to talk about alignment across payers. One of the challenges that occurs, and we heard this frequently, is that Medicaid does not act alone, particularly in the end if we want to change the actions of doctors, hospitals, clinics, etc., that they are not only participating in Medicaid, they are participating in Medicare, they're participating in commercial health plans, And in fact, in many cases, they are participating in multiple managed care plans. And so to the extent that all these plans have slightly different ways of trying to do things, diffuses the incentives, makes things a little more confusing. So improving the alignment across payers is really an important way to develop sort of collaboration and to meet those equity goals. And then finally, there needs to be some intentionality behind this. We need to have equitable outcomes that can be prioritized and thoughtful across all strategies. These should not be things that we fall into by accident. And to that extent, the primary care collaboratives' efforts to begin this conversation in a serious way, working with many others, hopefully begins to make improvements along those lines. And so that's the summary of the report. Again, it's a long report, not so long that it's going to take forever and ever for you to read, but it's a good, thoughtful report. What I'm going to do now is try to use the next segment of our discussion, which involves a discussion. It's led and moderated by Rob Houston. Rob is the director of payment delivery systems and payment reform at the Center for Healthcare Strategies. Has been involved in thinking about policies like these for many years, particularly in Medicaid. So Rob will be introducing a discussion panel, and he will introduce the panelists in just a moment. And with that, I will take my exit. Rob, it's off to you.
Thanks, Leighton, and thanks for the summary of the report. Hi, everyone. And I also like to thank PCC for inviting me to moderate this excellent panel. We have 3 great panelists to help us discuss this report in improving primary care in general. And if they can all come on screen, I will introduce them. There they are. So our first panelist is Matt Salo. He is the founder and CEO of Salo Health Strategies, a DC-based consulting firm specializing in healthcare policy and Medicaid market development and relationship building. He is the founding executive director of the National Association of Medicaid Directors, which he led for 11 years. Welcome, Matt. Christine Nguyen is the manager of Health Equity Strategies at Families USA. She has worked on health policy for a range of organizations, including the National Asian Pacific American Women's Forum, the Fairness Project, United States of Care, and the Center on Budget and Policy Priorities. Welcome, Christine. And finally, last but not least, is Jim Perrin, who is a professor of pediatrics at Harvard Medical School and past president of the American Academy of Pediatrics and of the Academic Pediatric Association. Recently, he helped to convene the Massachusetts Child and Adolescent Health Initiative, which worked to substantially expand Medicaid programs for children, youth, and families in the States. Welcome, Jim. So thank you all for being here. We have a number of questions that we want to get through in the panel, and then we'll turn questions over to the audience. As a reminder, as Sarah said at the outset, you can submit your questions through the chat, audience members, for us that we can answer later. So my first question for you 3 is kind of a general question. Why was this report needed? What is the case for a specialized report focused on Medicaid for primary care? And why is this a personal passion for you? Who'd like to start?
I'll go first. And thanks, everybody. It's great to be here. So I've spent my entire career working on behalf of state Medicaid officials and other state government leaders who run or care very, very deeply about the Medicaid program. And I can unequivocally say, it is the most important program, let alone health program, that exists in this country. We're covering close to 100 million people. Now that's going to end. It's going to drift off a little bit as the unwind of the public health emergency comes. But Medicaid's role is outsized in everywhere you look in the healthcare system. Coverage for kids, behavioral health, long-term services and supports. It is the backbone of the U.S. healthcare system. And Medicaid directors and people who care deeply about the Medicaid program, fully embrace that their obligation and their opportunity is to try to figure out how do we make the U.S. healthcare system work better for the patients we serve. And you get there through payment reform, you get there through payment policy, coverage policy, and it is a very easy thing for us to sit around and talk about, oh, well, let's solve equity this way, or hey, healthcare reform, let's solve it like that. But I think as Leighton kind of pointed out, there's no silver bullets. This is really, really complicated stuff, and it takes a lot of people working in tandem, policymakers, providers, the community writ large, to figure out how to do this. But the challenges around improving healthcare outcomes, improving healthcare access, whether that be from an equity perspective or more broadly within Medicaid, this is the opportunity for us to do it. So I was thrilled to be able to participate just a little bit in trying to get some of this out there.
I can take the mic next. Yeah, again, also thank you for PCC for inviting families and me onto the panel. Well, as we all know, Medicaid is the largest source of healthcare coverage in the nation. It covers over 80 million people, like Leighton had said, and also just people of color and other marginalized communities like the disabled, immigrants, LGBTQ folks are disproportionately enrolled in Medicaid coverage. So there are super deep equity implications in anything we do related to Medicaid. And Medicaid, more than any other program or payer, has the potential to reduce decades of healthcare disparities and improve the health outcomes for vulnerable communities. So that's really why, Medicaid is that source of care that we really need to think through when we're thinking about equity. And in primary care specifically, in theory, primary care is where we're having a lot of our initial interactions with the healthcare system. So as much as we can make the delivery and integration of primary care more equitable, especially for the Medicaid population, the more we can advance health equity. So I'm really excited about this report and just the ability for the report to ground and prioritize strategies to further equity and really ensure that people are able to experience health and not just healthcare.
Yeah, I would echo Christine's and Matt's comments. Matt commented this is a really big program, and it is. I mean, from a pediatric viewpoint, child health viewpoint, today Medicaid and CHIP cover 1 in 2 children in the country. That's an amazing percentage of kids that are covered by Medicaid. There's no other population outside of the elderly on Medicare who so depend on a public service and a public program. And Medicaid's an amazing program. It's done some extraordinary things. It's provided health insurance to large numbers of young people who would have no access to health insurance otherwise, would be fully uninsured at this point if we didn't have Medicaid. It also has some special provisions for kids that are pretty good. The EPSDT, which is part of the Medicaid statute in 67, a rather remarkable piece of legislation that helps to guarantee an adequate quality of care for children. We need to do it better, by the way, than we're doing now. But look, it's really there. There are all these things about no waiting periods, essentially no copays. It's actually quite an impressive program for what it does. And I think the report is amazing because it really does focus nicely on the things that we can do to make it a heck of a lot better than it currently is. And we should do that.
Great, thanks to all of you on that. So you mentioned the report, Jim. The report's authors identified 8 strategies. I think Leighton referred to it as the 8-fold path for strengthening primary care and Medicaid. So I have a 2-part question for you all. Number 1, what were your reactions to these 8 strategies? And number 2, which do you see as the highest priority for better care and to close gaps for Medicaid recipients?
I'm happy to go first this time. My reaction, initially, the report, I'm excited for everyone to see it. It does a really great job at laying out a pretty comprehensive set of recommendations to further equity in primary care through Medicaid, including some payment reforms, some provider-centered strategies, but something that me and the team at Families USA are really excited about and have already done a lot of advocacy around is the data justice piece and really pushing the health system to collect more disaggregated data. Earlier this year, we submitted a letter to OMB supporting the proposed changes to the race and ethnicity statistical standards and offering some concrete recommendations to streamline the process of collecting enhanced race and ethnicity data. And we're really pushing for this because we know how important better data is to inform our equity work, because we really can't be working on addressing health disparities if we don't know where those disparities exist. And the current data collection standard just isn't enough. And for example, I worked in the API and immigrant justice space before coming to Families USA. And just in the Asian American community, there are over 50 different ethnic groups. And we all have really vast economic, social, and health diversity in our communities. So that one Asian American category really isn't enough to capture the diversity of our community. And so for my community and many others, better data collection is really necessary to identify where the disparities lie and for us to begin to address those disparities. And I think the report does a really good job at furthering this by tying equity to payment incentives to really drive home those solutions. Because I think it's one thing to be collecting data and analyzing where we're underserved communities, and another thing to actually be working towards narrowing those disparities. And then I'll just uplift one more strategy from the report, because it's something that me and my colleagues are working really hard on, and I'm super excited to see it in the report. But we've been working for the last 2-ish years in developing strategies to ensure sustainable payment structures for community health workers. And CHWs are probably some of the most underutilized but most impactful healthcare workers in our system today. They're the people who are really working and living in community and doing a lot of that non-clinical healthcare legwork. They're advocates for community healthcare, they're educating peers on their health status and connecting folks to care and doing a lot of that important work that it's kind of taken for granted in the clinical space and especially in the payer space. But CHWs are super critical for immigrant communities, underserviced communities, and for people who just don't have the resources to stay on top of their care or be their own healthcare advocates. So CHWs really fill in that gap. So we're really excited to see that building sustainable payment structures through Medicaid for CHWs is a consideration in that report, because it's something that we've really been actively organizing around to really bolster up the primary care workforce.
I'd follow on Christine's comments. I think as a primary care clinician, we're really seeing transformative changes in what we're doing in primary care at this point. And this sort of notion of the physician opening a practice in a small community with maybe a nurse around if lucky, and a little bit of support staff is no longer the model we're moving toward. We're really moving toward much more of a team-based model of care. Physicians are important, but they're hardly the only player in primary care. And I think this particular report moves toward the kind of model we're after, which is really teams of people, physicians, nurses who actually manage chronic disease better than physicians do in general. The use of really the high integration of mental and behavioral health care. You all know the huge epidemic among young people in this country currently of mental and behavioral health. And it's not limited to the Medicaid population. It's a broad ranging problem that really has to be dealt with. And we've had good experiments that Leighton mentioned, where we have good evidence that this integration of behavioral health into primary care is tremendously effective, especially early on in upstream strategies to deal with the mental health crisis. And I'll end with a comment just to support Christine. Community health workers are really central to this. I actually don't think they should be limited to low-income populations. I actually believe that there's a huge value and role and importance of community health workers for all of us. If I don't understand what this doctor just told me this morning when I went to see him, community health worker may be really valuable to me, and I'm actually a pretty well-trained clinician. So I actually think that's a tremendously valuable step forward, and we've got to elevate that role and really make sure it works well, and we've got to pay for it.
Yeah. And I'll follow up on that. And I think this was great. I think, if I'm putting on a state government lens on this thinking, part of me is thinking, well, in the Medicaid system, as with any system, thinking about it from an economic standpoint, you get what you pay for and you get what you incentivize. And if you look at the healthcare system in any slice, you're like, if we were designing it from scratch, would we design it this way? And the answer is no, but there's a million reasons why we did it in the past, and it is the way it is. But if you really want to motivate any system, and keep in mind, healthcare is now what, 20% of the nation's GDP almost? That's a pretty big system. But if you want to motivate a system at the highest level all the way down to the lowest level to change, to do something differently. You have to build in financial payment incentives. And I think the good part is that there is a lot of talk in this report about how to kind of get there in terms of covering, paying more for primary care providers, absolutely covering community health workers, community health navigators, social workers, the connective tissue out there in the community. But one of the things that I think is going to be challenging, again, to put a state government lens on all of this is, Medicaid officials have to think about the big picture of, what are the financial consequences of changes or decisions that we make, and what are the political consequences? And I don't mean that as like a capital P political, but kind of like how the systems work together. So you can say, well, we'll just pay certain parts of the system more. Well, that may increase the budget, and Medicaid, which is already the largest or second largest component of every state budget, does it have the capacity to just pay parts of it more? It might be a good thing, but what are the consequences of that? So the trade-off is, well, do we pay more to the parts we want to increase and improve? And does that go hand in hand with perhaps paying other parts less, finding other parts of the system that we don't want to incentivize? Whether that's medical errors or whether that's inappropriate care or what have you. Do you figure out a way to sort of balance paying more for one thing with de-incentivizing something else? And the challenge, of course, that's the political part. Whose ox gets gored when they get paid less? And that's what state officials have to think about is, if this is going to be, if these types of investments, if this type of change is going to be self-perpetuating, self-sustaining, it's got to have buy-in at all levels. And that really is part of the challenge here. But I like a lot of what's in there. I really like, as Leighton called out, across payers. And just to hammer home that point, we're all part, providers are always part of multiple payers, multiple plans. And if it's too complicated, if a practice has 14 different, value-based arrangements they're trying to juggle, they're just going to throw their hands up and say, this is too complicated, I'm going to go back to the old way of doing things. And we don't want that either. So there's a lot of good here, but it's complicated and there's a lot of work still to be done.
Thanks. And I think, Matt, your comment has led well into my third question, actually, which is that the report focuses largely on strategies that address how care is paid for and delivered rather than other topics that are still important, like expanding coverage or improving benefit design. I'd like to ask each of you to share an example of a payment or delivery innovation from your own work that exemplifies one or more of the strategies articulated.
I'll lead right in from that. A lot of the talk around the community health workers and the patient-centered medical home model and thinking about this as a team really makes me, reminds me of conversations that I was having with actually the state of Arkansas. In Arkansas Medicaid back in the day when Arkansas Surgeon General Joe Thompson and their Medicaid leader Andy Allison were thinking about how to absolutely transform how Arkansas Medicaid worked from a provider perspective. And what they did was they went to physicians and said, we're going to think very, very differently about how we pay. And we've got the data to know, basically the baseline costs for people who are going to be in a fee-for-service system that doesn't really care coordinate, doesn't, focus on these other types of things. We're going to change the system and we're going to measure, where are the actual costs a year or two later? And if those costs are lower than what the baseline would have been, we're just going to take a huge hunk of that change and just give it to you. and potentially radically improving and increasing payment rates to providers. And they were like, oh, that sounds great, but how are we supposed to do that? And they would go back and say, look, I run a clinic or I run an office, and patients come in and I diagnose them and I give them a treatment and they leave. And when do I see them again? Next year? Do I don't really control whether they're following what I'm doing. I don't even know. How am I supposed to be accountable for this? And the answer was, well, you as the primary care physician shouldn't be responsible, but you build a team. You build that medical home, and it's gonna have nurses, and it's gonna have social workers, and it's gonna have community health workers, all working together to figure out, okay, how do we engage Mrs. Jones or Mr. Smith long after or long before they come into your office? Building that, but in helping them, not just saying, here's a new business model for you, good luck, helping them through practice transformation. That to me was kind of the core of everything that takes this stuff in theory and helps to translate it into reality, sustainable reality.
Yeah, I think that's right on target. And it's that concept of moving toward a life course or an ongoing approach to people rather than episodic approach to people that sort of underlays the Arkansas and other models. I'm just going to share quickly what we're doing in Massachusetts. Now, we don't know if it's going to work, by the way, because we're just in the midst of implementing it. There was actually a nice report in Millbank this morning about the Massachusetts experiment in transforming primary care. But in simple terms, we've gone from traditional fee-for-service. Actually, Massachusetts tried to do this 5 or 6 years ago, but what they ended up doing was simply paying the ACOs sort of a organized, accountable care money, but at the level of primary care, it was all the same fee-for-service widget production payment arrangement that developed. So the state has tried this time around to say, no. The monies that we're going to put into the system should be going at least 80% to the primary care practices in order to implement a totally different payment arrangement, which is basically a primary care partial capitation. And I think, again, we're just in the midst of putting it into place. But the concept is, there are certain things we still want to incentivize by fees for service. That does make some sense. Otherwise, you might end up cutting where they shouldn't be cut. But the large majority of the payment is really a per member per month payment, and practices get more money if they do a better job in the sense of having community health workers, having well-integrated mental and behavioral health in the practice, etc. So it's really incentivizing the kind of change in practice we want to see. Now, unfortunately, we're still not getting necessarily measured on the right outcomes. And one of the things in this report is really talking about trying to change the outcomes to population health measures. I think that's the next really interesting step. And my friends in Ohio tell me that, a few weeks ago, the governor said, we're investing all this money in Medicaid in Ohio. It's doing great stuff. You've done a great job with costs and cost containment. But you know what? Our statistics on kids are still lousy. We're the 33rd in this country on child mortality, infant mortality. Why are we not improving those outcomes? So we sort of said to the Medicaid program in Ohio, let's start measuring those outcomes instead. I think that's pretty exciting.
Great. And I think we're in a really different position than Matt and Jim. Matt is really great at the implementation side. Jim, I know you've been on the teams of building out a lot of pediatric models, but I think we at Families USA are in a really unique position where we're working with a ton of states and state-based partners and get to see how these models are getting implemented and hear firsthand how they're working to improve care or not. And then on the flip side, we have a pretty good working relationship with CMS. We get to check in with the folks there and encourage more of the good work that we're seeing, and then also working with them to address problems that might be popping up in the states. And so from that work, we've really been able to parse out over the years what works in primary care models and what doesn't. And I think what we're we're seeing is a number of Medicare models actually have a really great job, have done a good job at integrating primary care across other disciplines and moving away from fee-for-service to address equity and improve outcomes. So we've seen that the Oak Street model, which they provide a network of primary care centers that serve Medicare beneficiaries and under-resourced communities, have, even in the early stages, reported a 51% reduction in inpatient hospital admissions under their per member per month payments. And they've recently been acquired by CVS, so we're looking to see how that changes, but I've been really impressed by the initial findings. And another Medicare model that we're really big advocates of is the Vermont all-payer ACO model, which does a really good job at integrating behavioral health into primary care and uses that hub and spoke system to really better connect people to care and streamline that care. And through the Vermont ACO, they've seen significant reductions in acute care stays and readmissions, especially for people dealing with substance use disorder. So really thinking about how those Medicare models can be implemented in the Medicaid space. And of course, in terms of Medicaid models, the Oregon CCO model does a really good job at specifically addressing social determinants of health care for the Medicaid population and really improving care like outside of that clinical space. And the report touches on the Oregon CCO, so I won't delve too deeply into that, but I think the really great thing with models is that we can see what works for which populations and repeat those findings and those really good systems and improve care across the country. So I think we're excited as kind of like consumer advocates to really think about how we can expand components of successful models to improve equity and expand primary care and really use these innovations to make communities healthier.
Great, thank you. A lot of good examples from a lot of states. So we are, obviously this isn't going to be, this report comes out and everything is solved. There's going to be some challenges there. What are the biggest challenges that you all see to achieving the 8 strategies outlined in the report?
I'll go. I mean, I think any strategy for improving something is change. And big systems don't handle change well. And you have to make the change both simplistic and obvious and natural and beneficial for everybody involved. And that's very easy to say, it's very hard to do. I worry at this point now, I've spent 30 years working on behalf of states and being an absolute, staunch defender of the federalism model of let every state try, let 1,000 flowers bloom, and that what Oregon wants to try is going to be different than what Massachusetts wants to try, and that's good and that's right because that all makes sense. But I do think, as I'm getting older, that at some point we can't just keep saying let's let those flowers bloom and enjoy them from afar. And that if you want to get serious about payment reform, around equity, around systemic change, you have to kind of narrow it down, select which of those flowers are going to have the most relevance in the most places, and spread those as widely as you can to raise the baseline everywhere up as much as you can. And to Christine's point, like, oh my God, is there an actual Medicare solution? And again, I spent 30 years saying Medicaid's always better than Medicare for everything. But I think Medicare as an entity that operates in basically a single fashion across 50 states, if you can have some component of this primary care investment adopted by Medicare, that's how you get it adopted much more quickly, much more baked into the DNA and bloodstream of the healthcare system. So I think there's a point where you have to say, well, maybe not so much experimentation. Let's get some people off of the bleeding edge and try to raise the boats of everybody. And that can be a challenge, but I think that's important.
Yeah, I'll go ahead. I think the biggest challenges that I see in implementing a lot of these equity-focused metrics in Medicaid is just a huge workforce shortage, especially in primary care. I think that really comes down to the historical underinvestment in primary care. We just don't pay our primary care doctors enough for all that we ask them to do. And especially in Medicaid, primary care doctors just aren't getting reimbursed enough at all. And fewer medical students are entering the primary care space because of it. So there are less doctors even coming in to support the primary care workforce. And part of that is like also system failure. A lot of doctors who want to take Medicaid patients can, or at least could, take on lower reimbursement rates, but we've seen that doctors are having a hard time getting reimbursed under Medicaid without huge administrative burden, while other reimbursement is a lot more streamlined. So I think if we're tasking primary care to address health equity for the Medicaid population, which I think is the right solution because there's huge opportunities to reduce a lot of those healthcare disparities, we just need to funnel a lot more money into the space. And that's a challenge in and of itself. And then maybe even a bigger challenge on top of that is just moving away from fee-for-service, and how that's just how we've been paying for healthcare for so long. I think we're also seeing more and more that fee-for-service just like isn't working, especially in primary care. Fee-for-service doesn't value better health outcomes. It really places the value on volume and output in the healthcare system and not better health. So something my team and I were talking about the other day was how fee-for-service just really was nearly destroying that primary care model during the COVID pandemic. People weren't going in for their annual checkups, they weren't getting regular blood work, and that's how we pay our primary care physicians under fee-for-service. So the challenge there is really like the whole upheaval of the system and how we've been paying for healthcare for decades and decades. And I think we've been able to successfully move towards value-based payment models and smaller systems and models across the country, but we really have to think about how we can be moving towards that across the entire system as a whole.
So I would follow both of you guys, super ideas here, in saying a couple things. One is it's hardly limited to doctors. I mean, the whole workforce in healthcare, frankly, the whole American workforce in general, that's another story, is actually hurting right now. We're producing too few people to do it, and we're recruiting too few people to do it. That goes to nurses, community health workers, mental and behavioral health workers, etc. It's a big, huge problem, I would agree. And a lot of it is that the financing is just not very good. And I'd secondly say that the fee-for-service mechanism not only is messing up primary care, it's messing up the whole industry. We have these great, big, huge hospitals which are really still working on a fee-for-service model, which is entirely the wrong incentives for them to do the things that they really ought to be doing, frankly. So it's a much bigger problem, which gets me back to Matt's comment, which is it's a big problem. I mean, to really make the changes that we're talking about in financing, getting some degree of state similarity rather than many states flowering. I mean, I have colleagues who practice in Kansas City, and if they have a patient from Missouri, it's a totally different Medicaid program from a patient in Kansas. You can't make sense of it. And frankly, no person should get health services simply because of where she lives. That's not right. We need to really get a much more consistent program. Does that mean more federal oversight? I don't know. Is that manageable? What are the political aspects of that as well as we go forward? So I think those are very, very, very hard challenges. I agree that we need to sort of focus down on what are the doable challenges and move forward, but these all have got to be solved.
Yeah, definitely lots of challenges out there for implementation. I do want to get to the audience questions, but I do have one more question. I'm going to ask for one piece of advice from each of you. So as folks know, PCC is planning to use this report as a jumping off point for its Better Health Now initiative. If you could give one piece of advice, just one, to the primary care community on where and how to focus its attention in Medicaid, what would it be? And you can't say everything.
Yeah, I'll go. I think I would, if my advice is to people who are looking to engage state Medicaid leaders, I would say go into that conversation assuming good intent, but also understanding the dynamics that are out there. So if you just go and say, hey, why can't you fix this system for me tomorrow? Or why don't you just pay me more money? It's the right thing to do. That fails to understand what the other, the fiscal constraints, the budget balancing that has to happen, the other entities that might not get as much money. But to go to Medicaid and say, hey, I think we have a collective and a shared vision and a shared goal of improved equity, of improved outcomes, of improved access, of better managed care, however that looks. Let us be a partner to you. Let us help you overcome what some of those political or fiscal or just purely inertial challenges are to achieving that success.
Coalition building and collaboration.
Yeah, I agree with that, what both Matt and Jim have said, and also just like keeping in mind that equity work is a long game. These changes take a ton of time. Families USA, we convene a health equity task force and develop annual health equity priorities every year, and a lot of that is just carried on year after year because these changes aren't easily implemented. And it's worthwhile to acknowledge that achieving health equity is difficult and it requires long-term dedication. And as advocates, we have to celebrate the small wins, but also really constantly be pushing for more.
Great, thank you to all of you. So now we want to let the audience get involved. If there are any questions that audience members have for our panelists, please enter them in the chat. And Leighton, I'll ask you to join us back on camera because you may be able to answer some of the questions that we get right there. So one question that that I have here is that the report talks a lot about population-based payments in Medicaid, and I know that there are some population-based payments that are out there right now for primary care. CHCS, where I work, has a population-based payments primary care learning collaborative funded by Arnold Ventures and the Commonwealth Fund. Are there any particular approaches or models out there for population-based payments that you would particularly point to? I know that Jim, you were mentioning about Massachusetts's subcapitation effort there. Is there anything else? Because I mean, I come from the payment side of things on most perspectives. Is there anything else that we could, other good examples to lean on there?
So one might think about Leighton's comment early on about FQHCs, federally qualified health centers, which have a very unusual, interesting, moderately well thought through payment mechanism, which moves out of fee for service to a degree, not entirely, but moves to a different model of sort of paying for what works and what's needed to make things happen. Leighton, where's that going to go? Can we use that?
Well, FQHCs, you're right, have been exceptionally popular, have grown widely, and hopefully will continue to do so, but they run the slight risk that much of the FQHC program is funded through a grants and appropriations process. And because of that, it comes to the debates that happen every year in Congress. So right now we have, it's late August. Do we know what funding will be for community health centers come October? And the answer is we don't have the slightest idea. There are some proposals that could cut funding considerably. There are others to expand it substantially. We have at the range of variations on one hand, Bernie Sanders, who's chairman of the Health, Education, Labor and Pensions Committee in the Senate, who really wants to pump up community health center funding by doubling or tripling it over the past few years. On the other hand, on the House side, they're talking about basically essentially freezing it, which essentially means it's a cut because medical costs keep rising. So will we be able to sustain those things? Unfortunately, the Medicaid unwinding will sort of deprive community health centers a little bit of funding. But in the long run, community health centers are probably one of the things that has had bipartisan support over many years. Medicaid, by contrast, has been more controversial. And so to the extent that we can expect to see more of that going on, I think in the long run, we will continue to see community health centers grow. As far as the issue of sort of specific payment models, that's an interesting one, but there are other great examples like the one that Jim mentioned.
Okay.
Yeah, and I would probably somewhat not calling out as much great work as the clinics do within the system. I do think there does need to be some change, not perhaps the change they want to see, in how the clinics are financed, because within the Medicaid world, they do benefit from something called the prospective payment system, which is kind of it's a significant payment in which Medicaid does in fact subsidize a lot of care that is going on for the uninsured or the underinsured, and that's very important for the bottom line of the health of communities. But one thing it doesn't have is something I referred to earlier, which is an ability to kind of scale up or down payments on quality, on access. And there's no, I think what state Medicaid directors would argue for is, yes, we should pay them. Yes, we should pay them a lot, but we would want to see those payments tied more directly to quality outcomes, access outcomes, and very, very real metrics that can be measured. And potentially, and I know this is what scares people, but if there are entities that are not meeting those goals, then there should be consequences, like financial consequences. And we traditionally have not seen that ability within Medicaid. And that's something I think states would like to see. Not sure if that's going to happen.
Yeah. I do have one more question.
Trying value-based payment adjustments for FQHCs. So this is occurring, but once again, it's like so many value-based things. People like the principle, agreeing on the specifics, and knowing that they work is a little tougher.
I do have one more question I'd like to ask from the audience, which I'd like to get in here under the wire. And it goes to something Christine mentioned earlier. The audience member says that better disaggregated race and ethnicity data is so important. How can we improve data collection at a practical level when many provider organizations today have more than 30% of clients' race ethnicity data as, quote, not provided?
I can take an initial stab at this. I think one thing we could do on a practical level is just making sure that that information is streamlined and easier to answer. I think the race and then the separate ethnicity question around like white, not Hispanic is sometimes confusing for folks. I get confused sometimes when I'm like, okay, I'm Asian, but also am I not? So making sure that like that is all in our OMB recommendation. We recommend grouping those together, allowing people to submit their race, and then underneath there's an ethnicity. So Black, you could be Afro-Caribbean, you could be parts of Africa. It's just a little bit more streamlined and easier to understand rather than like the two, and one's not that comprehensive. So making sure that all that data is there and easy for the patient to fill out, and then also making sure that people are able to self-report that data. If a provider is looking at me, I'm also mixed race, so that might be confusing when you're looking at my face and submitting that information in your system yourself. So if I'm able to go in, really name who I am, and be able to like really recognize myself on that form, it makes it easier for both me as the patient and then for you as the provider to like really understand like who I am and then where I am along the, your whole broad community of patients, and where maybe disparities exist in my community. So that's kind of something that we have been like thinking about, and also like working with OMB to like streamline a little bit more, and also thinking about how that works in like the clinical space when you're thinking about how do I log in my ethnicity data when I'm at in the waiting room or at the doctor's office.
Thank you, Christine. Thanks, Matt, Jim, Leighton, for participating. And I am going to, in the last minute here, turn it back to Sarah to close things out.
Thanks so much, Rob. First, on behalf of the Primary Care Collaborative, I want to thank all of you, our audience, for joining today's event, but a special thanks to all of our speakers, so Rob, Matt, Christine, and Jim, for sharing their perspectives and experience. There was a lot there today to piece through, and also to the California Healthcare Foundation for their financial support, but also their leadership on this topic. PCC also thanks all the work group members, our key informants who contributed to this work. They're all listed in the report itself. And I want to personally thank Leighton for his many contributions today, but also over the past 6 months as PCC pursued this work. And finally, an acknowledgement of the full PCC team, the small but mighty team, particularly Noah Westphal and Kirsten Barboza for their many hours of researching this important topic. So we are looking forward to seeing where the Better Health Now campaign takes its Medicaid advocacy in the months ahead. Until then, please send us your comments on the report, tune in for PCC's monthly webinars, and join us in DC in November. Thanks, everyone.